Hello everyone. Let's now discuss the topic of mitral valve prolapse. Very important one. Often you get questions for your exam, mitral valve prolapse. So mitral valve prolapse is in fact a very common disease that is affecting the mitral valve. And if you ask me to be specific on the site of pathology for the MVP or mitral valve prolapse, I'll tell you the site of pathology is the mitral valve apparatus. Okay, is the mitral valve apparatus, MV apparatus. Okay. And this entity of MVP is the most common cause of a primary mitral regurgitation. It is the most common cause of primary MR. Okay, all right. Now let's see more about the pathology of this entity of mitral valve prolapse. Okay, let's see more about the pathology. Well, mitral valve prolapse happens because of a myxomatous degeneration of the mitral leaflets. Okay, so it occurs because of a myxomatous degeneration. Myxomatous degeneration. So, from a histologic point of view, what happens is a proliferation of the spongiosa part of the mitral valve leaflets. Okay, there is a proliferation of spongiosa of the mitral valve leaflets. That's what is seen histologically. There is increase in the concentration of glycosaminoglycans. Okay, there is increase in the concentration of glycosaminoglycans, and there is excessive water content as well. Okay, there is excessive water content as well. Okay, so this is what happens. So basically what happens is a excessive mitral leaflet tissue. That is what happens in a MVP, excessive mitral valve leaflet tissue. And this thick elongated mitral valve, I can call it a thick elongated mitral valve. So this thick elongated mitral valve will have a tendency to prolapse. And such a valve with a tendency to prolapse is called what? A floppy mitral valve. It's called a floppy mitral valve. Okay. And when you compare the anterior and the posterior mitral leaflet, please remember that the posterior mitral leaflet is usually more affected than the anterior. The posterior mitral valve leaflet, this is important, that is more commonly affected, okay, than the anterior. Now you also have elongated chordae with a reduced strength. This can actually rupture. So they can develop into a, say, a progressive annular dilatation and can even lead on to a mitral regurgitation. So MVP can lead on to MR. Okay. So MVP, mitral valve prolapse, can lead on to mitral regurgitation. Okay. And also remember, the MVP can cause excessive stress on the papillary muscles. So it is having some sort of affection on the papillary muscles as well, MVP. So there is stress on the papillary muscles leading on to maybe some sort of a ischemia and dysfunction of the papillary muscles, and also the adjacent ventricular myocardium. And because of this, it can also predispose to certain arrhythmias, MVP can predispose to arrhythmias by causing a ischemia and dysfunction of the papillary muscles and adjacent the ventricular myocardium. So that point is also important. So I hope you have got an idea regarding the pathology of mitral valve prolapse. Now moving on to the etiology. Why does this occur? Okay, why does this occur? What is the etiology of mitral valve prolapse? So the exact etiology of this entity is not known. Okay, exact etiology is unknown. Exact etiology is unknown. And some cases may have a genetic basis. Some cases has a genetic basis in the form of a autosomal dominant pattern of inheritance with incomplete penetrance. Some cases can have alteration in the production of type 3 collagen. Okay, alteration in production of type 3 collagen. Okay, that's also important. And patients with mitral valve prolapse can also have certain association with certain connective tissue diseases. Okay, they can have association with connective tissue diseases, which is again important. And what are the connective tissue diseases? You can have Marfan syndrome. Okay, Marfan syndrome, osteogenesis imperfecta, osteogenesis imperfecta, and also the famous syndrome that is the Ehlers-Danlos syndrome. Okay, Ehlers-Danlos syndrome. Okay, so these are some important etiological associations. In addition to these disorders, please understand there can be certain rare causes of MVP, which can include acute rheumatic fever. You can have an ischemic heart disease, maybe cardiomyopathies leading on to MVP. And even a small percentage of patients with ostium secundum ASD, ostium secundum ASD, they can also go on to develop mitral valve prolapse. So that is it about the bunch of etiologies that can lead on to this entity of MVP. Let's move forward and discuss the clinical features of this entity. Clinical features. So first of all, what is the age group of this entity? It is 15 to 30 years of age. That is the age group. And commonly, females are more affected than males. And it's interesting to note that most of the patients with MVP are asymptomatic. So they are asymptomatic and remain so for the rest of their life. And many of the patients are in fact diagnosed based on auscultatory findings, which subsequently leads on to evaluation by the echocardiography. Okay. So a good number of patients are totally asymptomatic throughout their life. And if at all symptoms develop, and that occurs because of a significant MR. Okay, so suppose if a patient develops symptoms, and the symptoms are often due to either a significant mitral regurgitation or because of a cardiac arrhythmia So majority of the patients, however, MVP patients, however, have a mild MR. Okay, if at all the MR occurs, this is usually a mild, a trace MR. And always a severe mitral regurgitation is uncommon. But there is a rare subset of patients who can lead on to a severe mitral regurgitation, that is usually patients above 50 years, where patients can develop dyspnea and heart failure. Okay, patients can develop dyspnea and heart failure. Okay, and as I told you, patients can develop cardiac arrhythmias either in the form of ventricular premature contractions, paroxysmal supraventricular tachycardias, atrial fibrillation, and ventricular tachycardias. So these are the arrhythmias that can happen. And what are the manifestations? Patients can have a palpitation, pre-syncopal episodes, syncopal episodes, and sometimes you can even have an atypical chest pain. Okay, you can even have a atypical chest pain as well. In addition to symptoms, more common symptoms like palpitations, pre-syncope or syncope. Okay, so these are the clinical features of mitral valve prolapse. And let's move on to the examination findings. Because I've already made a mention that the majority of the patients are asymptomatic and they are diagnosed on auscultatory findings. So the most common auscultatory finding in patients is a non-ejection click. Okay, very important. Is a non-ejection click. And this can be either single click or multiple click. So usually it's a mid or late systolic click. Okay, mid or late systolic click. Okay, so do not confuse this non-ejection click with the ejection click that happens with the opening of the aortic and the pulmonary valves. Because as you all know, when you talk of systolic clicks, okay, systolic click can either be what? Ejection or non-ejection click. Ejection click as well as non-ejection click. Now the question here is, why is there a click? Okay, why is there a click first of all? See, what happens is during the time of systole, there is a sudden tensing and snapping. Okay, there is a sudden tensing and snapping. So snapping means there is a sudden break. Okay, the sudden break is there of the elongated caudate tendinae and the prolapsing leaflets. Okay, of the elongated caudate tendinae and the prolapsing leaflets, and this is what is responsible for the non-ejection click. Remember, it's a mobile click. Okay, what do I mean by a mobile click? Mobile click means the timing of the click can vary with certain maneuvers that alter or change the left ventricular volume. So that is what we are going to see very soon. So the click, the non-ejection click, is usually followed by a murmur, which is a high pitch, okay, a high pitched murmur, which is mid to late systolic in timing, high pitched, mid to late systolic murmur, mid systolic murmur, and this is best heard at apex. Best heard at apex. Okay. Now this murmur, that is your high pitch mid to late systolic murmur, can radiate. So the radiation of the murmur depends on which is the involved leaflet. Now suppose you have got a predominant involvement of the posterior leaflet, or there is a posterior leaflet prolapse. Okay, think of a scenario of a posterior leaflet prolapse. In such case, the jet of the mitral regurgitation is directed anteriorly and the murmur will radiate to the base of the heart. Okay, so the radiation will be towards the base of the heart. Whereas in case of an anterior leaflet prolapse, in such a case, the jet of the mitral regurgitation is directed posteriorly and the murmur will radiate to the axilla. There is a radiation of the murmur to the axilla and the back. Okay, the murmur radiates to the axilla and the back. So some patients, remember, can also have a scenario of a mid-systolic click without a murmur. You may also have certain patients who have a murmur without a click. So there are such possibilities as well. Next subheading in this is about the dynamic auscultation in MVP. This is important. Dynamic auscultation in MVP, important. So dynamic auscultation in MVP means, see, if you have any activity that decreases the left ventricular volume. So suppose there is an activity that decreases the LV volume, like standing and say Valsalva. Okay, standing and Valsalva. These are maneuvers that decrease the LV volume. So in such a case, there is an exaggeration of the tendency to prolapse. Okay, there is a exaggeration of the tendency to prolapse. Okay, so in such a scenario, what happens is the click and the murmur moves close to the S1, because I told you it's a mobile click, correct? So in this scenario, when there is an exaggeration of the tendency to prolapse, the click and murmur, the non-ejection systolic click, moves close to S1. Okay, moves close to S1. Whereas if you have any activity that say increases the LV volume, okay, increases the LV volume, as in case of squatting and isometric exercise, squatting and isometric exercise, in such a scenario, there is a decrease in the tendency to prolapse. Okay, there is a decrease in tendency to prolapse. Okay, and then what happens is the click and the murmur moves close to the S2, the second heart sound. Okay, the click and murmur moves close to S2 or the second heart sound. Okay, so let's have a look at the image as well. Patient in the supine position, the standing position and the squatting position. So as I told you, any activity like standing, which will decrease the LV volume, you will see that the click and the murmur is moving close to S1. Whereas in case of squatting, when there is an increase in the LV volume, in that case, the click and the murmur is moving close to the second heart sound. To sum up whatever I have taught you so far, I want to tell you that MVP is a condition that can have a range of clinical presentations. Some patients only have a systolic click and murmur with a mild prolapse of the posterior leaflet, and patient might not have any other symptoms at all. At the same time, you can have a certain patient with a severe mitral regurgitation due to a rupture of the chordae tendineae and a flail leaflet as well. In majority of the patients, the condition actually has a slow progression over years or decades, whereas in a small subset of patients, there can be a rapid progression as a result of the rupture of the chordae or maybe even endocarditis. Okay, so I hope you got the overall clinical picture of the mitral valve prolapse. Now, what about the lab evaluation? What about lab evaluation in mitral valve prolapse? Let's see that. So, lab evaluation, number one, about the ECG. Okay, so ECG in case of MVP is usually normal. Usually normal. You can have certain non-specific changes. Sometimes maybe some ventricular premature contractions, T-wave inversions, rarely some arrhythmias, but usually it is normal. What about the role of echo? What about the role of echo? Remember, MVP is diagnosed usually by a transthoracic echocardiography, which will demonstrate the prolapse of the mitral valve leaflets. It will help to assess the subvalvular structures as well. It will help to assess mitral regurgitation. It will help to assess any other hemodynamic consequence of the MVP. All this is possible by the echocardiography. And there is an echocardiographic definition of MVP as well, which is defined as a systolic displacement of the belly of the mitral valve leaflets. Okay, systolic displacement of the belly of the mitral valve leaflets by at least 2 millimeter into the LA, by at least 2 millimeter into the left atrium. Important. Okay, at least 2 millimeter into the left atrium, that is superior to the plane of the mitral annulus. Okay, superior to the plane of mitral annulus. Okay, so this is the echocardiographic definition, of a mitral valve prolapse, and this is in a parasternal long axis view. Okay, this is in a parasternal long axis view in echo. This is the definition. Okay, I hope the definition is clear. Now, what about the role of transesophageal echocardiography, TEE? Well, the role of transesophageal echo is when there is inadequate acoustic windows on TTE, and you want to have more accurate anatomical details, then you can go for transesophageal echo. And also in certain scenarios where you go for an intraoperative guidance during a valve repair, in that scenario also you will go for a transesophageal echocardiography. Okay, so that's it about the lab evaluation in case of mitral valve prolapse. Finally, moving on to the medical management and surgical management. The management part, first of all, about medical management. So about medical management, well, surgical management. Coming to the surgical management. So surgical management, well, suppose you have got a case of a symptomatic severe mitral regurgitation. Okay, you have got a patient with MVP with a symptomatic severe mitral regurgitation. In that case, you will go for a mitral valve repair. Okay, you will go for a mitral valve repair. Okay, and in case the patient is having a significant LV systolic dysfunction, okay, LV systolic dysfunction, okay, that is also a significant LV systolic dysfunction. In that case, also go for a mitral valve repair. Always remember, it's always repair that is preferred over replacement. Okay, all right. And in patients, in a certain subset of patients who are having a severe primary mitral regurgitation due to a MVP and a high surgical risk. So patients with high surgical risk, you can go for a minimally invasive procedure. I have already discussed this before. It is called TER. That is a transcatheter edge-to-edge repair. That is the one that is preferred. So these are the important points about mitral valve prolapse. Just to end, let me add one more point, that is about the other names for this entity of mitral valve prolapse. You can call it, since you have a click and a murmur, one name is a systolic click murmur syndrome. Okay, you can call it Barlow syndrome, which is again another alternative name. You can call it floppy valve syndrome, and also billowing mitral valve leaflet syndrome. Okay, so systolic click murmur syndrome, Barlow syndrome, floppy valve syndrome, billowing mitral leaflet syndrome. So these are the other terminologies or other names for this entity of MVP. So MVP, simple but important topic. Okay.